Welcome back to the Deep Dive. Today we are walking straight into the operating theater to deal with a real heavyweight. We are talking about the largest organ in the abdomen, a chemical factory that literally never sleeps.
And for a surgeon, it's a landscape that is both, incredibly forgiving and at the same time absolutely unforgiving.
It's a total paradox of an organ, isn't
It
it?
really is. I mean, you can cut away 70, even 80% of it, and it grows back like some kind of magic trick. But if you nick the wrong vein behind it,
Yeah.
you've got maybe 3 minutes to save that patient's life before they bleed out entirely. It demands respect.
We are talking, of course, about the liver. And specifically, we are doing a deep dive into Chapter 69 of the 28th edition of Baily and Love's Short Practice of Surgery.
The definitive guide. I mean, for any surgical trainee listening, that's your Bible.
Exactly. Now, before we scrub in, let's just, set the mission parameters for everyone listening. This deep dive is designed to be your ready reckoner. We are taking the dense, sometimes pretty dry text of Chapter 69, which is packed with diagrams and flowcharts. And we are turning it into a working mental model. We're going to use metaphors, anchors, case studies, anything to make this stuff stick.
But I have to add a massive disclaimer right at the top.
Please do.
This conversation, it does not replace the book. You absolutely need to see the diagrams of the Hiller plate. You need to read the fine print on all the variations of the hepatic artery. Consider this the steel framework that holds the house together.
Right.
But you still have to go in and furnish the rooms yourself by reading the actual text.
Deal. A perfect analogy. So let's start with the why. Why does the liver get its own massive chapter? What is the headline feature that separates it from, say, the spleen or the kidney?
Well, it really comes down to 2 superpowers, if you want to call them that.
Superpowers, I like it.
The first one is regeneration. The liver is completely unique in the human body. In Greek mythology, Prometheus had his liver eaten by an eagle every day.
And every night it grew back.
Exactly. The Greeks knew something we're only just really mastering. You can remove up to 80% of a healthy liver, and within weeks, it will regenerate almost to its original volume.
That's just astounding.
It is. If you take half a heart, you're left with half a heart. If you take half a liver, eventually you pretty much have a whole liver again.
Which completely changes the math for surgery.
Yeah.
It means you can be so much more aggressive with tumors in a way you just can't be with other organs.
Precisely. But then there's the second superpower, and this is the one that causes the nightmares down in the trauma bay.
Let me guess. The plumbing.
The plumbing. The dual blood supply.
This is a classic exam question, a real stumbling block. So let's unpack it slowly. Most organs have, one artery in, one vein out? Simple. The liver, not so much?
Not at all. It's greedy. It takes about 20% of its blood from the hepatic artery. That's the fresh oxygenated stuff, pumped straight from the heart via the aorta. That makes sense?
Okay, Steve.
But it gets a massive 80% of its flow from the portal vein.
And the portal vein is the one bringing all the blood up from the gut, right? From the intestines, the spleen.
Right. And that blood is low in oxygen, but it's incredibly rich in nutrients and also toxins from whatever you just ate. This dual inflow dictates absolutely everything.
How so?
Well, it's why liver trauma bleeds so catastrophically, because you have 2 high-volume hoses pointed at it. But it's also why, in a real emergency, we can sometimes tie off the hepatic artery and the liver won't die.
Because the portal vein keeps it on life support.
Exactly. It's this weird built-in backup system.
So we have a regenerative beast with a very weird plumbing system. Let's look at the map. Section 1, the lay of the land, anatomy.
Okay. So when most people picture the liver, they see 2 big lobes, a right and a left. And they usually think the dividing line is that ligament you can see right down the front.
The falciform ligament.
Throw that idea out. Just get rid of it. That is surface anatomy. It means absolutely nothing to a surgeon.
So it's a false landmark.
A complete red herring. If you cut along the falciform ligament, you're cutting right through functional tissue on both sides. We need to look at the liver not as 2 lumps, but as a city with 8 distinct postal codes.
These are Cuneau's segments.
Exactly, named after the French surgeon Claude Cuneau, who first described them. Segments I through 8. And the absolute beauty of the city concept is what we call the unit theory.
Go on.
Each segment is its own self-contained island. It has its own inflow stalk, so a little branch of the portal vein and the hepatic artery, and it has its own outflow drain, which is the bile duct. They all travel together in a little bundle.
The portal triad.
The portal triad, yes, which means You can remove segment 6 without shutting down the power grid for segment V.
Right. You can take out one block of the city without causing a citywide blackout.
Precisely. It turned liver surgery from, hacking off a chunk and hoping for the best into a form of precision engineering. But to navigate the city, you need to know where the border is.
So if it's not the falciform ligament, what is the true functional divide between the left and right liver?
It's an invisible plane. It's called Cantley's line.
Let's visualize this. For everyone listening, if you need to, just pause for a second. Look at your right hand. Open your palm. Now draw an imaginary line from the base of your thumb down to the center of your wrist.
That's a great way to picture it. In the body, that line runs from the gallbladder fossa, the little hollow where the gallbladder sits, straight back to the inferior vena cava, the IVC. That is Cantley's line.
So that's the real border wall.
That's the wall. Everything to the right of that is the functional right liver. That's segments V, 6, up, and 8. Everything to the left is the functional left liver, segments 2, 3, and 4.
Got it. Now, in this city of 8 segments, there is one weird outlier, isn't there? Segment 1, the caudate lobe.
Ah, yes. Segment UN is the hidden bunker. It sits deep in the back, kind of wrapped around the IVC. Surgically, it's a real pain to get to.
Why do you call it a bunker? What's so special about it?
Because it's off the grid. See, every other segment, 2 through 8, they all drain their blood into the 3 main hepatic veins. The right, middle, and left. Those then dump into the IVC. But the caudate lobe,
It does its own thing.
it has its own little private drainage veins that go directly into the IVC. It completely bypasses the main sewer system.
Okay, that's a cool anatomical quirk. But why does that matter to a doctor standing at a bedside?
Because it perfectly explains a condition called Budd-Chiari syndrome.
Right.
Imagine the main hepatic veins get clotted off. Thrombosis. The city's main sewer lines are completely blocked. Segments 2 through 8 swell up, they get massively congested, they start to fail because they can't drain their blood. But the bunker...
The bunker has its own private drain.
So it survives. In fact, it does more than survive. It hypertrophies. It gets huge to try and compensate for the rest of the failing liver. So if you ever see a CT scan with a massive caudate lobe and a shrunken, dying liver all around it, you should immediately think Budd-Chiari.
That's a fantastic anchor. Caudate lobe equals survivor bunker. Okay, speaking of seeing things, Baily and Love breaks down the different imaging modalities: ultrasound, CT, MRI, PET. Let's give the listener a one-word definition for each, a way to know which tool to pull from the belt.
Good idea. Okay, ultrasound is the flashlight.
Flashlight.
It's cheap, it's fast, you can bring it to the bedside, you use it in the dark, in the emergency room. It's fantastic for seeing fluids like bile in a dilated duct or solid things like stones in the gallbladder.
But its weakness.
If the patient is obese or there's a lot of gas in the gut, the flashlight beam just reflects back. It can't penetrate, so it's limited.
Okay. CT scan.
The CT is the architect's blueprint. This is the gold standard for anatomy. If I'm planning to cut, I need the CT. It shows me the vessels, the segments, the fractures and trauma. It maps out the city with incredible precision.
And the MRI. How is that different?
The MRI is the tissue detective. Let's say the CT shows a blob, a lesion. We know where it is, we know how big it is, but we don't know what it is. Is it a cyst full of water? Is it full of fat? Is it cancer?
Right.
The MRI looks at the magnetic properties of the tissue itself. It can tell the difference. It solves the mystery of the blob.
And finally, the PD scan.
The PET is the heat map. We inject a type of radioactive sugar, FDG. Cancer cells are greedy. They have a really high metabolic rate.
They're hungry.
They're starving. They eat up all the sugar and they light up bright on the scan. We use this to see if a known cancer is active or if it has spread, if there are metastases to other parts of the body.
Flashlight, blueprint detective, heat map. Perfect. Keep those distinctions in mind.
And before we move on, let's just do a quick check-in.
Good call. All right, listener. Visualize Cantley's line again. From where to where? If you can't see that line from the gallbladder fossa to the IVC in your mind's eye, seriously, stop and rewind. Also, what is the survivor bunker? Which segment survives when the main hepatic veins are blocked?
If you didn't say segment I, the caudate lobe, go back and listen to the Budd-Chiari explanation one more time.
These concepts are the absolute foundation. Everything else builds on them.
It really does.
So let's move on. Section 2. The fortress under attack. Liver trauma.
This is the bread and butter for any emergency surgeon. The liver is big, it's heavy, and it sits right up under the ribs. If you get hit hard in the torso, the liver is almost always going to take some of that impact.
Okay, so let's run two scenarios to illustrate how we think about this. Case A, a motorcyclist goes over the handlebars at, say, 60 miles an hour, chest hits the ground, crushed ribs on the right side. That's blunt trauma. Case B, a bar fight. Someone gets stabbed with a knife in the right upper quadrant. Penetrating trauma. Which one makes your heart rate go up more?
You know, intuitively, most people think the knife, it's a weapon, it's actively penetrating the organ, it feels more violent. But clinically and statistically, I am much, much more worried about the motorcyclist.
Really? Why is the blunt trauma so much worse?
It's all about energy transfer. The knife damages only the tissue it physically touches. It cuts a track. The motorcycle accident, on the other hand, involves massive deceleration forces. The liver is heavy, but it's held in place by these flimsy ligaments. When the body stops suddenly, the liver keeps moving.
So it tears itself off its moorings.
It tears from its attachments. It can literally shatter the parenchyma, the substance of the liver. And maybe more importantly, it's usually associated with other major injuries, rib fractures, lung contusions, splenic rupture, head injuries. The mortality for severe blunt trauma is significantly higher, 10 to 30%, compared to maybe 12 to 20 for penetrating.
Now, the management of this has undergone a massive revolution in the last 20 years. Baily and Love calls it the conservative shift.
A huge shift. It used to be if you had any kind of liver injury on a scan, we wheeled you straight to the operating theater and cut you open.
The old mantra, a chance to cut is a chance to cure.
Something like that. We felt we had to fix it. We were surgeons, we cut things, that's what we did.
And what did we learn from that approach?
We learned that quite often we were making it worse. See, when the liver bleeds inside the closed abdomen, the pressure builds up. That pressure, that hematoma, it actually acts like a tamponade. It pushes back against the bleeding point and helps it to stop.
It's like a natural cork in a bottle.
Exactly. When you cut open the belly, you release that pressure, you pop the cork,
and all hell breaks loose.
Suddenly, a manageable, contained bleed becomes a torrent. So the rule now is, stability is king. If the patient's blood pressure is holding, if their heart rate is stable, we do not touch them with a scalpel. We put them in the ICU, we scan them, and we watch and wait.
Baily and Love says up to 80% of blunt trauma is now managed without surgery. That is a staggering number.
It is. We treat the patient, not the CT scan. The scan might look absolutely terrible, a shattered liver, a so-called liver fracture. But if the patient is awake and talking to you and has a good pulse, you have to hold your nerve.
But let's take the other scenario. They aren't stable. The motorcyclist is crashing, BP is dropping, heart rate is through the roof, the fluids aren't working. You have to go in.
Have to. So you do a big midline laparotomy, you open the abdomen, there are liters of blood. You can't see a thing. It's like a swimming pool of blood. The first rule of clumbing applies here. You have to turn off the main tap.
This is the Pringle maneuver.
It is the single most important maneuver in all of liver surgery. You reach into the abdomen with your hand. You find the free edge of the lesser omentum, that's the hepatoduodenal ligament, and you clamp it hard.
With what?
A big vascular clamp is best, but you can use a shoelace, a catheter, or just your fingers, whatever works.
And what are you actually pinching off when you do that?
You are occluding the entire inflow, the portal vein and the hepatic artery. You are stopping all the blood flow into the liver.
Okay, so the tap is off. The pool should stop filling up. But there's a clock ticking, right? The liver can't survive without blood.
A very loud clock. The liver can survive about 45 minutes of what we call warm ischemia time. If you go much longer than that, you risk irreversible damage, liver failure. So you clamp, the bleeding slows right down, and now you have a window to suction out the blood and actually see where the damage is.
Okay, so here's a check-in question for the listener. This is absolutely critical. You've done the Pringle maneuver. The inflow is clamped tight. But you look down, and the liver is still pouring out dark venous blood. What does that tell you?
That is the nightmare scenario. If the inflow is off, but it's still bleeding, the blood must be coming from the outflow. That means you have an injury to the hepatic veins, or even worse, the IVC itself, where it runs behind the liver. That's a retrohepatic venous injury.
And that's harder to fix.
Much, much harder. Because you can't easily clamp those veins, the mortality rate for that injury is astronomically high.
Okay, but let's go back to the better scenario. The Pringle works, the bleeding slows, you identify the big smash on the right lobe. You don't have time to meticulously stitch every little vessel because the patient is cold, acidotic, and their blood isn't clotting anymore. What do?
You pack it. But there is a real technique to packing. You don't just stuff gauze sponges into the crack in the liver that acts like a wedge. It just splits the liver further apart.
Right.
You have to pack around the liver. You place large abdominal packs between the liver and the diaphragm and between the liver and the rib cage. You're trying to compress the entire organ back into its original shape.
It's like sandbagging a levee during a flood.
A perfect analogy.
Yeah.
Then you close the skin temporarily, often with just a plastic sheet or a special zipper, to keep that intra-abdominal pressure high, and you get out.
That's damage control surgery.
Exactly. You fix the physiology in the ICU, you warm them up, you give them blood products, you fix the clotting, and you come back to fix the anatomy 24 or 48 hours later.
High-stakes stuff. Let's move from the chaos of the trauma bay to the slightly more controlled chaos of the medical ward. Section 3. The plumbing problem. Portal hypertension.
We're back to that portal vein again. It's the key to everything. Imagine the liver is a fine mesh filter. In cirrhosis, which is usually from chronic alcohol use or hepatitis, that filter gets clogged with scar tissue. The liver becomes hard, like a rock.
So the blood coming up from the gut, that 80% of flow, it hits a wall.
It hits massive resistance. The pressure inside the portal vein just skyrockets. The blood can't get through, so it has to find a way around. It starts looking for back roads to get back to the heart.
And this is collateral circulation.
Right, and these back roads exist in very specific places, in the lining of the stomach, the esophagus, and the rectum. But the problem is, these are tiny little veins. They aren't designed to handle the massive volume of blood coming from the entire gut.
So they swell up under the pressure.
They become varices, these thin-walled ballooning veins just waiting to pop, and if the pressure gets too high...
Pop, and that is a red alert emergency.
It is one of the most dramatic medical emergencies. It looks like a murder scene. The patient is vomiting huge volumes of bright red blood. The mortality rate is very high. You have to move fast.
Okay, walk us through the algorithm. Patient comes in, hematemesis, vomiting, blood known history of alcohol abuse. Go.
Step 1, resuscitation. ABCs. But, and this is absolutely key, do not over-resuscitate.
What do you mean? Don't you want to get their blood pressure back up?
Not to normal, no. If you pump them full of fluids to get their BP back to 120/80, you are just increasing the pressure in those varices and you'll blow the fragile clot right off. You want something called permissive hypotension. Keep them just alive enough.
Okay, that's counterintuitive but makes sense. What about drugs?
Antibiotics immediately. Because infection is a huge trigger for bleeding and is a major cause of death in these patients. And a drug called terlipressin.
How does terlipressin help?
It's a vasoconstrictor that specifically targets the splenic circulation, the blood vessels of the gut. So it squeezes the inflow before it even gets to the liver. It's like turning down the tap a little bit so there's less pressure pushing against the blockage.
Smart. So the pressure's down. Now you need to physically stop the leak.
Endoscopy. You get the gastroenterologist, you go down with a camera. The gold standard is banding. You find the bleeding varix, you suck it into the tip of the scope, and you fire a tiny little rubber band around the base. It strangles the vein, and the bleeding stops.
And that's better than injecting chemicals. Sclerotherapy.
Much better. Sclerotherapy was the old way. It causes more ulcers and complications. Banding is safer and more effective.
But what if you can't see anything? There's just too much blood. Or the banding fails. The patient is dying right there on the table. You need a bridge to something more definitive.
You need the Sengstaken-Blakemore tube.
Okay.
It's an archaic, nasty-looking device, but it saves lives. It's basically a tube with 2 balloons on it. You shove it down the patient's nose or throat, you inflate the gastric balloon in the stomach and pull it up tight against the gastroesophageal junction. Then you inflate the long esophageal balloon.
It's basically putting a giant internal thumb on the bleeding point.
It is a pneumatic tamponade, yes.
Right.
It's brutal but effective. The catch is you can only leave it in for 24 hours max, or it will cause the esophagus to rot from pressure necrosis. It buys you time to arrange the definitive fix, which is TIPSS.
TIPSS, transcircular intrahepatic portosystemic stent shunt. That is mouthful. What is the simple explanation?
Think of it as drilling a bypass tunnel. The main highway through the liver is blocked by a massive traffic jam, cirrhosis. So the interventional radiologists go in through a big vein in the neck, the jugular, and they snake a wire down into the liver. And they literally punch a hole connecting the high-pressure portal vein directly to the low-pressure hepatic vein. They then put a metal stent in to keep that tunnel open.
So the blood just skips the liver entirely.
It bypasses the traffic jam, the pressure in the portal system drops instantly, the varices deflate, the bleeding stops.
But there's a cost, right? The whole point of the liver is to filter that blood.
Correct. A huge cost. If you bypass the filter, all the toxins from the gut ammonia specifically go straight to the brain. The patient can develop a condition called hepatic encephalopathy. They get confused, drowsy, their personality changes. They can even become comatose.
So it's a trade-off. You accept the brain fog to prevent them from bleeding to death.
A very stark trade-off, yes.
Okay, listener, do you have that algorithm? Resuscitate, but gently. Terlipressin and antibiotics. Endoscopy with banding. If that fails, the balloon bridge. Then TPSS is the definitive tunnel. That's your roadmap.
And remember why TPSS causes confusion? It bypasses the filter.
Got it. All right. Section 4. Let's talk about invaders and infections.
So liver abscesses, a collection of pus in the liver. We basically divide these into two types, pyogenic, which means bacterial, and parasitic.
Pyogenic is usually your standard gut bugs, right?
Yeah.
E. coli, Klebsiella, climbing up the bile duct because of a stone or a stricture.
Exactly. It's called ascending cholangitis. And this gives you the classic, absolutely must-know for exams, Charcot's triad.
Okay, quiz me. What is the triad?
Number 1, fever, usually with rigors, so violent shaking chills.
Right?
Number 2, jaundice, the patient turns yellow.
Okay.
And number 3, right upper quadrant pain.
Fever, jaundice, RUQ pain. If you see that triad, what is happening physiologically?
It means there is pus under pressure in the bile ducts. The system is blocked and infected. The bacteria are being forced back into the bloodstream through the liver. The patient is septic. You can give all the IV antibiotics you want, but they won't work until you drain the pus. You need urgent decompression, usually with an ERCP.
You have to drain the swamp.
They have to drain the swamp.
Now, let's talk parasites. Specifically, the hydatid cyst. This is the one that comes with a big flashing do not touch warning label in the textbook.
It certainly should. Hydatid disease is caused by Echinococcus granulosus, a tapeworm found in dogs and sheep. It forms these incredible cysts in the liver that are full of what we call daughter cysts and a highly allergenic fluid.
So a patient comes in, they have a cyst on their scan. It looks a bit weird. Why can't I just stick a needle in it to get a sample and see what it is?
Because if you stick a needle in a hydatid cyst and it leaks even a tiny drop, 2 terrible things can happen. First, the patient can go into immediate, profound anaphylactic shock and die right there on the CT table.
Wow.
Second, you spill those microscopic daughter cysts, the hydatid sand, into the abdominal cavity. And now the patient has disseminated hydatid disease. You've turned one local problem into a systemic, incurable disaster.
So the number one rule of hydatid cysts is?
Do not poke the angry bear. Diagnosis is made on serology blood tests and the characteristic look of the cyst on the scan.
And if you have to operate on it, how do you do it safely?
You have to kill it before you open it. We surround the area with pads soaked in a scalicidal agent like hypertonic saline, 20% salt water. We carefully aspirate some fluid and inject the saline into the cyst to kill the parasite inside. We wait. Only then, when we're sure it's dead, do we open it up and suck out the contents.
Salt is the weapon. Okay, final section. The really heavy hitters. Section 5. Tumors. The unwanted guests.
And we can classify these pretty simply. Benign, which mostly you leave them alone, and malignant, which you usually have to get out.
Let's start with the benign ones. First up, the hemangioma.
This is just a tangle of blood vessels. On a scan, it looks like a lake of blood. It is by far the most common benign liver tumor, and the rule is simple. Leave it alone. Do not biopsy. It will bleed like crazy. It almost never causes trouble.
Okay, easy enough. Next, FNH. Focal nodular hyperplasia.
This one scares people because it looks like a proper mass, but it's just disorganized but otherwise normal liver cells. The absolute key on the scan is the central scar. If you see a lesion with a central scar in a young woman who feels perfectly fine,
Leave it alone.
leave it alone. It has no malignant potential. It does not turn into cancer.
But then there is the adenoma. This is the exception to the rule.
The adenoma is the troublemaker. It's the one to watch, and it's strongly linked to the oral contraceptive pill.
So the classic scenario is a young female patient on the pill.
Exactly. The problem with adenomas is twofold. They are unstable, meaning they can bleed spontaneously into the abdomen, which can be a life-threatening emergency. And unlike the others, they have a roughly 10% chance of undergoing malignant transformation, of turning into cancer.
So we don't leave these alone.
No. First step is simple. Stop the pill. Sometimes they'll shrink. But if it stays larger than 5 centimeters, the recommendation is to resect it, to cut it out.
Got it. Hemangioma, leave it. FNH, leave it. Adenoma over 5 centimeters, resect it. Now for the bad stuff. Malignancy. Let's start with primary cancer. Hepatocellular carcinoma, HCC.
The metaphor here is a weed growing in damaged soil. HCC almost always arises in a liver that is already cirrhotic from decades of alcohol or chronic hepatitis B or C.
Which makes surgery really tricky. It's not just about cutting out the weed, because the soil it's growing in is still bad. The remaining liver might fail because it doesn't have enough functional reserve to handle the stress of the surgery.
That's the central dilemma, and that's why, for many patients, the best treatment for HCC isn't just resection, it's a full liver transplant. You replace the weed and the bad soil entirely.
But organs are scarce. We can't give them to everyone, so we need strict rules on who gets one.
And this is where we get the Milan criteria, the rule of 5 and 3.
Okay, what is it?
To qualify for a transplant for your HCC, you must have either one single tumor that is less than 5 centimeters, or you can have up to 3 separate tumors, but each one must be less than 3 centimeters.
And if you have more disease than that, a bigger tumor, or more of them.
You are outside the criteria. The data shows the outcomes are poor, the cancer almost always comes back, so unfortunately you don't get the transplant.
A tough reality. Finally, let's talk about metastases. Secondary cancer, usually from the colon.
Right. The liver is the first capillary bed, the first filter for all the blood coming from the gut. So it's the first place colon cancer cells get trapped. It used to be that if you had liver mets, it was game over.
A death sentence.
Palliative care only. But the chapter highlights this massive, massive shift in attitude.
We're much more aggressive now.
Incredibly aggressive. For the right patients, we can achieve 5-year survival rates hitting 50%. For a condition that used to be considered terminal, we are even doing something called the liver-first approach.
Which means what, exactly?
Traditionally, you take out the primary colon cancer first, then deal with the liver later. But if the liver metastases are the most immediate threat to the patient's life, we go in and we fix the liver first. We resect the mets, let the patient recover, and then go back for the colon tumor a few weeks later.
That's a huge strategic change. And this leads us to probably the most sci-fi procedure in the whole book. The ALPPS procedure.
ALPPS, yes. Associating liver partition and portal vein ligation for staged hepatectomy.
That is a mouthful. Break it down for us. What fundamental problem is this solving?
Imagine you have a huge tumor occupying the entire right side of the liver, say 70% of the liver volume. You want to cut it out. But the left side, the future liver remnant, is too small. It's only 30%. If you leave the patient with just that tiny piece, they will go into liver failure and die.
So historically, that patient is inoperable.
Inoperable, correct. But with ALPPS, we hijack the liver's regenerative power. In step 1, the first operation, we go in and we tie off the portal vein going to the right side, the tumor side. And then, this is the crazy part, we physically split the liver tissue right down the middle along Cantley's line.
You actually cut the connection between the left and right lobes.
We do. We leave the tumor in place for now. But by cutting that connection and diverting all of that nutrient-rich portal blood flow to the small left side, we send a massive, undeniable biochemical signal to that healthy left lobe. Grow now.
You are force-feeding it.
We are, and it responds. It hypertrophies at an incredible rate. In just 7 to 14 days, that little left lobe can double in volume.
That is unbelievably fast.
Once our scans show it's big enough to support life on its own, we go back in for step 2. We remove the entire diseased right lobe.
You are essentially farming new liver tissue inside the patient's own body to make a previously impossible surgery possible.
It is the ultimate application of physiology to solve an anatomical problem. It's truly incredible.
Wow. We have covered a massive amount of ground. Let's just do a quick recap.
Okay. We've mapped the city using Kuno's segments and Cantley's line. We've learned that in trauma, patience saves more lives than scalpels. But when you do have to act, the Pringle maneuver is your absolute lifeline.
We've seen that bleeding varices are a plumbing problem that need bridges, like the balloon, and new tunnels like TIP PSS. We know that you never ever poke a hydated cyst, you kill it with salt first. And for benign tumors, we know that for an adenoma, you stop the pill.
And we've seen that modern liver surgery is pushing the boundaries of what's possible with paradigm shifts like liver first and mind-bending techniques like ALPCS.
Which leads me to a final thought for our listeners. Baily and Love mentions things like robotic surgery and virtual reality training as the future. But if we look at ALPPS, where we are actively inducing and manipulating regeneration, how far are we really from the next logical step?
You mean growing a new organ outside the body?
Exactly. If the liver wants to regenerate so badly, can we one day just take a few of a patient's healthy cells, grow a fresh new liver segment in a lab, and then just swap it out? No more donor lists, no more immunosuppression drugs, replacing the bad soil of cirrhosis entirely.
That is the holy grail. We are moving from being, carpenters, just cutting out the rotten wood, to being gardeners, actually growing new, healthy tissue. Reading a chapter like this makes you feel like we are standing right on the edge of that frontier.
A fascinating and hopeful place to be. Listeners, remember, this was just the Ready Reckoner. Please go read Chapter 69, look at the diagrams, understand the details.
Knowledge is always patient safety.
Thanks for diving deep with us. We'll see you on the next one.